Ready? Yep. Okay, well, good afternoon, everyone, and thank you for joining us. This is another one of the webinars sponsored by the Drexel Climate Change and Urban Health Research Center, CCUH. Also in partnership with the SALURBAL study, Salud en América Latina Climate. And today we are very fortunate to have an invited speaker, Dr. Yang Liu, who is a leading scientist in the area of environmental health impacts. Dr. Liu received his PhD in environmental science and engineering from Harvard University, and he is currently a distinguished professor and chair of the Department of Environmental Health at the Rollins School of Public Health at Emory University. And his research focuses on applying satellite data in particular to investigate, population exposure to a range of environmental factors, including air pollution, extreme heat, wildfires, and UV radiation, and looking at their health impacts. So a very important and timely area. He is a member of numerous, a lead researcher in a number of collaborative research projects, but most relevant to today, he is director of the NIH-funded Climate and Health Actionable Research and Translation Center CHART at Emory, which is one of our fellow P20 centers. So we are very happy to have him share some of his work and thoughts with us today on the health impact of exposure to wildland fires. So thank you so much for joining us, Yang. We appreciate it. Thank you.
Thank you very much, Dr. Diaz-Ru, and thank you all for taking the time to join this webinar. It's a pleasure for me to share some of my work with you. I suppose we keep all the questions and comments in the end.
Yes, that's probably easiest. Yeah.
Okay, great. So should I get started?
Yes, please do.
Okay. All right, great. Since this is my first encounter with the Drexel people and then other colleagues, I want to tell you a little bit about my group. So as Anna introduced, that my group is a kind of a hardcore data group. At the center of our research agenda is the production of data products through our in-house exposure model development or other ways of fusing data to support other environmental health studies. And in general, we take in 3 types of information to support model development. The primary one, kind of the bread and butter business of our group, is satellite remote sensing. We use pretty much all the available Earth observing satellite data instruments to support mostly atmospheric remote sensing because it's the most relevant to air pollution. We also collect and analyze local sensor data in addition to regulatory monitoring data. On our climate side of the research, we either take advantage of existing climate model simulations, or we collaborate with our co-investigators to generate our own custom-made downscale climate model simulations. And these sources of information will be fused through either statistical modeling or machine learning algorithms to produce full coverage exposure estimates. And the outcome of our models is used to drive different types of research. For example, we're interested in environmental justice and climate justice research. Our group and our collaborating groups are heavily involved in environmental epi studies, and we also do climate-related health impact assessments. And between the different components of this research framework, we also have kind of a interlinked research from different sources. For example, we couple satellite remote sensing with ground-based local sensor to run hybrid ground truthing to support satellite missions. and also to use the satellite data to produce novel exposure metrics at the spatially resolved pattern. We also deploy low-cost sensors in the EJ communities or other under-resourced communities to engage the community and co-create solutions and mostly in a local setting. And we can also use satellite data together with the downscaled climate model simulations in the bias correction scheme. We can also directly apply downscale climate simulations in the health impact assessments. So overall, there are a lot of kind of ideas coming out of this rather complex but interlinked scheme. And before I start, I want to acknowledge my group because I lead the group, but they do the work. And if you're interested, just search Emory remote sensing. You'll find our group, our work, our data products as well. And then I want to acknowledge funding support from NIH and NASA. Okay, so fires. Wildfires or fires in general are the sort of the perfect research nexus between three things: climate change, human health, and air pollution. Climate change, as we know, intensifies fire activities. It prolongs fire seasons. On the other hand, as climate change moves fires closer to us, we are also moving closer to fires. This is the ever-expanding wildland-urban interface. So in a sense, we are getting into the fire's way as well. And fire smoke as health risk factors, they are likely to be different from the widely studied ambient air pollution. And the overall field and the literature is much more limited. If you compare the fire and smoke related EPI studies and exposure modeling studies, they are probably 2 orders of magnitude smaller than the ambient air pollution studies. So overall, the field is very young. It has a lot of potential. And also, we found, as a exposure group, we found estimating fire exposure very interesting, and it's crucial to quantify its associations between these different types of exposure metrics and the adverse health outcomes. Einstein used to say, the more I learn, the more I realize how much I don't know. Well, actually, I don't know if Einstein actually said that, but I found it on Google. But it definitely reflects my overall experience when I study fire and fire-related health impacts. Specifically, there are fundamental questions to be asked and answered. For example, well, what do we mean by exposure? What are the health burden, and are there any other sorts of burdens related to this exposure? And who are the population at risk? These seemingly straightforward and kind of simple questions actually need answers, and the answers may not be that straightforward. So in this presentation, I'm going to share 3 case studies to just share with you my thoughts on these very basic fundamental questions. The first study is a subchronic wildfire-related exposure study, and the endpoint is lung cancer surgery recovery. The second one is a acute wildfire-related exposure study, and the endpoint is anxiety disorder in ED visits. And then the last one is our work in progress. Here we want to estimate the excess mortality due to fire smoke exposure in the United States. So first one, this study is a collaboration with the American Cancer Society funded by NASA. Basically, the ACS is very interested in cancer prevention. And our collaborator, Dr. Leticia Noguera, who's on the pictures on the right-hand side of the slide, asked the question that if it is possible to link the proximity to wildfires with cancer recovery after surgery. It's a pretty novel question that I have never thought about. So a student, back then a data analyst, Danlu Zhang from my group, the picture on the upper left-hand side of the slide, went to design the study and executed it. And the method is it's a Cox proportional hazard model design where we compare the mortality hazard among individuals experiencing a wildfire event during their recovery from lung cancer surgery. And we compared that with similar individuals who did not experience a wildfire during their recovery period. And here, as you can see, the exposure is not fire smoke. It's the episode of fire. And in this case, how do we identify a fire? We did it through satellite data. Satellite instruments such as MODIS provides a active fire product. It's called Collection 6 Thermal Anomaly Product. At 1 kilometer spatial resolution, this product goes back 20 years. So we can take advantage of the entire National Cancer Database. And the NCDB covers over 70% of all diagnosed cancer patients in the United States. And then the exposure assessment is, in this case, it's simple, right? So we basically say if someone who resided in a particular zip code with at least one satellite detectable active fire within 12 calendar months after discharge following this person's lung cancer surgery would be considered exposed, right? So it's if a fire took place in this person's zip code within a year after the surgery, this person is considered exposed to the fire event. And in this database, we found that about 16% of our study population were exposed to wildfire. And then their mean age of cancer diagnosis was 67 years. And during this 16-year study period, there were 126,000 deaths. To our surprise, we found that individuals residing in the south or southern U.S. were more frequently exposed to wildfires. It's a little counterintuitive, right? From the media, we always see or hear that there are one mega fire after another in the western U.S. But in reality, the southeastern U.S. in particular have constant fires, smaller fires, but they burn tens of thousands of times each year. So this table shows our kind of the summary results of this study. And as you can see, the findings are pretty surprising. So basically, the three rows in the table shows the exposure window. And then the right-hand side shows the adjusted hazard ratio out of the proportional hazard model. And what it says is if a patient experienced a fire event within 3 months of hospital discharge, he or she had a 43% more chance of dying after surgery. And this effect remained statistically significant even if the fire or the experience took place 7 to 12 months after surgery. And we further stratified our analysis by cancer stages, right? So when we analyze stage 1 cancer patients, stage 2 and stage 3, this not only the effects, but also the pattern persisted. So regardless of the cancer stage, these patients will be negatively affected if they were exposed to a fire event. And if you look at the hazard ratio values, they are in general much larger than those reported in air pollution epi literature. If you're familiar with that, we'd be happy to see something like a 1.1 or 1.08, right? Here we're talking about 1.4, 1.5, and we're not even, linking pollution concentrations with these health outcomes. We are linking a particular event to a outcome. And then we see very large effect size. It indicates that we are perhaps dealing with compound exposure. So the experience is not just about inhalation of smoke. It's probably something else as well. For example, the patient's property or the community might have been contaminated. The water and soil might be contaminated. They may experience trauma, anxiety, and other things that would hinder or adversely affect their recovery. But the mechanisms behind this very large health effect are unknown. We simply don't know what actually happened to these patients. And the last point I want to make is that again, we are working on this from different angles, but we want to make this point that despite the larger fire sizes in the West, actually people live a lot closer to fires in the East, and especially the Southeast. So they are actually more exposed to fire. So up to this point, when we completed the study, we kind of avoided the challenge that we actually don't have a quantitative measure of smoke exposure. So we set out to actually estimate smoke exposure. And the idea came from our biostatistician, Howard Chang. And again, Dan Liu executed the model development and training and prediction. Our modeling strategy is the kind of the hard. We took the hard route. So the blue boxes you see here on these equations are CMAX simulations or chemical transport model simulations with fire emissions turned on and off. So we asked the model to consider the state of the science model simulations with and without fire, and use those simulation results as the key predictor of smoke PM 2.5. So this pair of models will give us the total PM concentration estimated, and then the background or non-smoke PM concentration estimated. So their difference is the smoke contribution. Of course, we have to separate smoke impacted regions from non or unimpacted regions. I'm gonna spare you the gory details. The paper's published last year. If you're interested, feel free to read it and send me any questions if you have any. And this is a very busy slide. It shows the vast amount input data to train such a model. And what I want to show you here is that this is a model heavily driven by satellite data products. All these boxes represent satellite data. And then in the end, the model produces something like this. At 1 kilometer spatial resolution, full spatial coverage, the model produces daily estimated smoke PM concentration and ambient PM concentration independently. And as you can see from these 4 figures, the top 2 are the model estimated total PM concentrations. And the spatial patterns are similar. It's just, back in 2007, pollutions were heavier. And then overall, there's across the board decline of total PM concentration thanks to the effective air pollution control or emission reduction policies. On the other hand, if you look at the lower half of the slide, these are smoke contributions to PM 2.5. And the spatial patterns can change dramatically from year to year. For example, 2007 is a large fire year, not only in the West Coast, but also in the southeastern US. On the other hand, in 2018, there are mega fires on the West Coast, but the fire activities on the East Coast were not so much, right? So you see, large swings of pollution hotspots. And this happens at the daily level. And we also went ahead to sort of analyze the impact of fire smoke on air quality monitors over time, because we are curious to learn how much of a long-term effect fire smoke has become. And then, as you can see from this bar chart, on average, out of the 1,800 or so regulatory air quality monitoring sites, about 40% of them, or about 800 monitors, are on average affected by heavy smoke events for at least a month a year. And I didn't show another slide here. If we considered the entire US population, about 299 million people, nearly 100% of the US population were affected by fire smoke for at least one day. Basically 100% coverage, right? So it tells me at least that fire smoke is not just a kind of exotic natural disasters anymore, because it happens so frequently. We are constantly affected by it. So the second case study that I want to share with you is about anxiety. And why do we care about anxiety? Because anxiety disorders is one of the main outcomes of mental health issues. And anxiety alone, anxiety plus mood disorders accounts for about 50% of all the disability-adjusted life years due to mental health issues. And this is based on a 2019 GBD study. And this work was carried out by my postdoc, Dr. Qingyang Zhu. Show his picture there. Also want to put a plug. He's on the job market. If you're looking for some hardworking, brilliant postdoc, you have one. Feel free to contact him. So the study design is pretty straightforward, right? We're using ED visits from 5 Western US states between 2007 and 2018. And this is a case crossover design, and we're using the ED visit weekday within a particular month as the case, and then all the other weekdays in the same months, the same weekdays in the same months as control. But here we again ask the question, what exposure means, right? In addition to fire smoke, what else can we account for during these fire events? Well, again, we turn to NASA. NASA produces this active fire spot data I just talked about in the cancer recovery study. It also produces a fire intensity measure called fire radiated power, or FRP. It measures how hot a particular fire is. And we basically included all of them. We created multiple exposure metrics related to fire events. And the most classical one is just a 48-hour average smoke PM concentration. And we use that number to classify or to define a major smoke event categorical variable, which is if smoke contributes to more than 75% of the total PM concentration on a particular day. We call that day having a major smoke event. And then we have these, satellite measured fire spots or active fires. We also have the cumulative FRP. So we have 4 exposure metrics in the first model, in model 1. And in model 2, we also adjusted for the background PM 2.5. And then this table summarizes our findings. As you can see, without background PM, smoke PM 2.5 has a significant impact on anxiety disorder ED visits. Once we adjust for background PM, that effect becomes not significant, okay? So what it says is, okay, smoke alone, inhaling smoke over a 2-day period, well, it's not likely to increase the risk of ED visits because of anxiety disorders. On the other hand, experiencing a major smoke event, or in this case, 75% contribution probably means you see the smoke plume. Experiencing such a event will cause an increased risk in ED visits. And this estimate is significant in both models, adjusted and unadjusted. And then seeing active fires or seeing the flame doesn't cause anxiety. Feeling the heat of the fire doesn't really cause anxiety. And then we did stratified analysis, and we found that, okay, the reason that inhaling smoke doesn't cause anxiety is that it only affects a small proportion of the population. In our case, it's patients 65 years or older. In our ED data, this is about 9% of the total population. And it's, it affects both men and women, right? So it's not that smoke doesn't make people anxious, it's just smoke makes the elderly population more anxious. So again, to summarize, we found a statistically significant association between increased risk of ED visits for anxiety disorders and different smoke or different wildfire or fire exposure metrics. The fact that when you compare smoke inhalation with witnessing a heavy smoke event, it seems to suggest that there might be 2 separate pathways. So the inhalation of smoke is more of a physiological pathway. The eyewitnessing of heavy smoke plumes might be physiological. Right? It concerns you when you see black smoke coming your way. And then our stratified analysis actually showed the elderly population are more susceptible. I didn't show additional results. Additional results also show that females are more susceptible than males. Now, move on to the third case study. Here, we want to take a deeper dive on the composition of smoke. And from ground measurements, we know that fire smoke is rich in carbonaceous species. So this is the most sort of distinctive feature of smoke when you compare smoke particles with ambient PM. Smoke particles contain about half of carbonaceous species. And in theory, they will be more toxic to many of the health endpoints. But we don't really know that because we don't have readily available exposure estimates. And if we want to estimate, say, the mortality burden of smoke exposure, we also don't have readily available concentration response functions. So our solution is first to estimate organic carbon and elemental carbon concentrations due to smoke, and then take advantage of the most recent study on smoke mortality CR relationships. So this work is still being wrapped up by my student Zhihao Jin. And we haven't submitted the paper yet, so please don't cite or quote us. And as you can see from this previous slide, the availability of PM speciation monitors in the US is a lot sparser than total mass concentrations. Together, we have about something like 400 or 500 monitors over the years to account for long-range smoke transport from, say, Alaska and Canada. We went over the border and collected speciation measurements from southern Canada as well. And even with that, we have a much smaller model training data set, which forces us to have to take a little a fancier approach. So Zhihao developed a multi-stage meta-learning approach in order to stabilize the OC-EC exposure concentration estimates. And this slide shows you the result. And again, our OC-EC concentration estimates are taken at the daily level at 1 square kilometer resolution. And this is a pretty busy slide. We're trying to show the time trend of smoke OC, smoke EC, background OC, background EC in different climate regions in the US. And then we also included southwestern Canada and southeastern Canada. As you can see, the black lines are backgrounds, and across the board, background OC and EC have been declining pretty steadily. On the other hand, if you look at the red and orange lines, they're much bumpier because fire activities have major impacts, and they have cycles over time. And you see they don't necessarily go down. Some of the years have much higher smoke contribution than other years. And then overall, if you look at the CONUS time series, which is one of the lower of the two larger line plots, and you can see smoke EC concentration has been increasing, and smoke OC concentration has been increasing. And if we count the days of smoke impacts, we have, on the northern part of the US and southern part of Canada, wildfires affect PM concentration, wildfire OC-EC affects PM concentration about 150 days per year. And there's also about 100 days being affected by long-range transport. For example, smoke from Alaska or smoke from the Yukon. The little purple circle in the southeastern US, you can see actually smoke impact days are more. They're more abundant, right? Combined smoke OC and EC, we will see 230 days on average each year. And then about 200 days out of that 230 are probably affected by prescribed burning in this region. And this is, again, just to show you the very different spatial patterns of background versus smoke, organic carbon, and elemental carbon. I'm gonna have to move a little bit faster here. And like I said, there are very few studies on smoke-specific mortality risk estimates. We have collaborated with Dr. Kai Chen's group at Yale. They published a paper on long-term exposure to wildland fire smoke and mortality in the contiguous US. Now, here, the exposure is not organic carbon or elemental carbon from smoke. This is total smoke PM 2.5. And what they did is to provide the estimates in terms of change in monthly mortality rate or change in annual mortality rate per 100,000 persons by smoke concentration size bands. So we can, if we assume OCEC from smoke carry the same amount of toxicity as total smoke, we can use these risk estimates to calculate or estimate attributable deaths due to smoke exposure, due to OCEC smoke exposure. And this is what we found. County level annual mean attributable death, of course, in California and then on the West Coast in general, you see heavy impacts. But if you look at the Eastern US, it's not like this region is immune to smoke impact. You still have, especially if you look at Florida, many counties in Florida have been heavily impacted by prescribed burning. And I have to note here that currently our model is not able to differentiate wildfires from prescribed burning or agricultural burning. They're all lumped together as fires. And if we use the value of statistical life to estimate the cost, the financial impact of being exposed to organic carbon, elemental carbon from smoke. This bar chart again shows the kind of the same trend that we've seen in the cancer study. The three colors represent three different regions in our study domain. And even though the cost estimates fluctuate from year to year, the biggest contribution is not really from, nationwide, the biggest contribution is not from the West. The biggest health burden actually comes from the southeastern part of the United States, where you have a lot of agricultural burning and prescribed burning. And again, this is probably because these fires are much closer to densely populated regions. So when you think about mortality, you have to have exposure. You also have to have people, right? On the West Coast, you got mega fires, but most of them start from remote regions. And then when the smoke plume reaches, say, San Francisco or LA, they are much diluted. So from this, we see that, the background PM concentrations have been declining. However, if you account for fire contributions, in some of the regions, especially Western US, that trend has been reversed since 2014. So it's no longer declining. The total PM is no longer declining as wildfires are becoming a major contributor of air pollution. By major contributor, I mean 25% or more. And this is where we have for power plants or traffic, right? They each count about a quarter of PM 2.5. And exposure to fire smoke is associated with significant health risks, as well as billions of dollars in terms of extra healthcare costs. For comparison, the state of California spends about $2 billion fighting fire each year. And if you look at these numbers, in a mega fire year, say 2018, the overall health costs is over $100 billion. And then again, I want to reiterate this, although there are a lot more large fires, attracting public attention. If you think about the actual health burden, population density and proximity to wildfire smoke are key factors that you cannot ignore. Okay, so some overall takeaways from these case studies that I just shared with you. Number one, fires are more than smoke. We have to keep that in mind, that fires are a multifaceted threat to human health, both physiologically and psychologically. You know, defining the exposure is actually tricky. It can be smoke, it can be proximity to smoke, it can be proximity to fire. It can also be something that's not easy to measure. For example, smoke contaminated environment. And also, it can be the trauma you experience in a large fire event. It could be the fear of loss of your property, loss of your social network, loss of your care team, and also displacement, right? You may be evacuated. And wildfires are linked to a wide range of negative health outcomes. I just showed you a bunch of seemingly unrelated health outcomes. You know, anxiety, of course, respiratory, cancer recovery, and all-cause mortality. And then finally, the population at risk actually can vary depending on the disease and exposure. Because I showed you that it could be women that are more vulnerable. It could be the elderly. It could be cancer patients in their recovery phase. And we have other studies to show that sometimes people with comorbidities are more vulnerable. Other times, people without comorbidities can be more vulnerable. It all depends on the health outcome and then the setting of the study. So overall, I want to say, this is a very exciting field, and it's a very kind of a young field. There's a lot to learn here. And last but not least, our group is interested in more than just fires. We're also interested in collaboration in extreme weather, like heat exposures, ambient indoor and outdoor air pollution. We're also working on some more novel climate-related risk factors, such as pollen exposure. And I'm happy to learn more from you, and I welcome opportunities of future collaboration. Thank you very much.